Well, hi, everybody. My name is Abby Melendez. I'm a ThyCa volunteer. I'm also the director of ThyCa support groups. If you're here, you're in session 254, which is monitoring of low and intermediate risk papillary and follicular thyroid patients in the first 5 years after initial treatment. And we're here with Sana Ghaznavi, MD, and I'm going to, there she is, she's waving, and I'm going to read you a little bit bio about Dr. Ghaznavi. Dr. Ghaznavi is an endocrinologist and neuroendocrine tumor team leader at Tom Baker Cancer Center in Calgary, Alberta, Canada. Dr. Ghaznavi is an academic endocrinologist at the University of Calgary, Canada. She graduated from the University of Alberta Medical School, completed internal medicine and endocrinology residency at the University of Calgary, and completed an interdisciplinary thyroid cancer fellowship at Memorial Sloan Kettering Cancer Center in New York, New York. Woo. That's where I'm from. Her practice focuses on the management of thyroid cancer patients. Her research interests include active surveillance of papillary microcarcinomas, resensitization therapy for radioiodine refractory thyroid cancer, and personalization of thyroid hormone replacement therapy.
All right, thank you guys so much for having me, and I'm excited for this talk. I'm just going to share my screen now. I'm guessing it will take about 45 minutes, so we will have time at the end for questions, comments, and just general discussion. So as stated, this talk is going to be about monitoring of low and intermediate risk papillary and follicular thyroid cancer patients in the first 5 years after initial treatment. In general, I'm going to be using some medical terminology and things like that, and so you will see that, but my intention is to basically give the vocabulary and the words that we use to communicate about thyroid cancer patients, but also explain the background of what it means and make it more practical. And I've got some practical tips in there about things that you should be aware of or ask your own treatment teams and that sort of thing. So, okay, so my talk, we're going to start by defining what are low and intermediate risk patients. What does that mean? The second part is going to be talking about dynamic risk stratification of patients. And so that already is a complex term, and I'm going to break that down. The third is, so when we talk about monitoring, we use what's called a risk stratified approach. That essentially means we don't use the same approach for every single patient with thyroid cancer. It depends on the particular case. And then the fourth thing is just room for discussion and for questions. So starting off, let's define low and intermediate risk patients. So what do we mean by that? When we talk about risk stratifying someone, what we say is if there's, a general cohort of all the patients that have papillary and follicular thyroid cancer, then we're going to separate them out into groups where we think of patients as lower risk, higher risk. And so what is that risk of? And so when we talk about thyroid cancer, when I meet a patient for the first time as an endocrinologist, I talk about their cancer stage, and you'll hear people colloquially in movies, friends, family members, everyone talking about, well, what is your cancer stage? And for thyroid cancer, that is stage 1 through 4. And it depends on your age at the time of diagnosis, and it depends on your what's called TNM, which stands for tumor node, lymph node, and metastases. And so I won't be talking about that today, but I'm presenting it just to make sure that we understand that that's not the part that defines what's called low or intermediate risk. So essentially, stages, what is the risk of dying from thyroid cancer? The other type of risk in thyroid cancer is risk of recurrence, which means what's the likelihood that this cancer will grow back? And that's where the terminology low and intermediate and high risk comes from. So the focus of this talk will actually be the risk of recurrence. What's the likelihood the cancer is going to grow back after I've had my initial treatment? Something like having your thyroid removed and maybe radioactive iodine afterwards. So how does your medical team determine your risk of recurrence? There's a lot of different variables that have to be integrated to determine your risk of recurrence. So it doesn't just come down to what was the size of your tumor or where is it spread, if it has spread. It's a number of different variables, and you can think of those as before the surgery, the actual surgery, and then what we learn after the surgery, after the thyroid is removed. So before the surgery, pre-operative, we use things like the neck ultrasound that was done that found the thyroid nodule in the first place, and also assessment of your vocal cords, which is typically done by a thyroid surgeon. The second is operatively. So this is when a surgeon is actually operating and they're looking, they're visually inspecting inside the neck. And the questions as an endocrinologist that I ask from the operative report is, did the surgeon think the thyroid cancer was poking out of the thyroid? And was it stuck to other stuff in the neck, like your food pipe or your windpipe? And ultimately, was the surgeon able to remove the entire tumor, or was it because it was stuck to things they weren't able to remove the entire tumor? And then the post-operative variables that we look at are the pathology report. So that is something where when the thyroid comes out, the pathologist chops it up, looks at it under the microscope, and gives us a number of really important things about the thyroid nodule or the thyroid cancer, such as what was the size of it, what is the type? So is it a papillary? Is it a follicular thyroid cancer? And also, what is the subtype? Because certain subtypes can be more aggressive. And then also, what was the lymph node status? So were there lymph nodes involved that had thyroid cancer in them? And then there's a host of other variables, but those would be some of the most important ones. We also look at your post-operative thyroglobulin level, which is your tumor marker for thyroid cancer. And then for patients who get radioactive iodine, we look at the whole body scan results. So when you take radioactive iodine after the treatment, you get a scan head to toe, and that tells us where the radioactive iodine went. And it shows us if the cancer has spread outside of the neck. So essentially, we integrate all of these different variables, so preoperative, operative, postoperative, and that together gives us a risk of recurrence. And so the risk of recurrence system that I'm referring to specifically is the one that's the most commonly used in the world, but not the only system. And that is the system that comes from the American Thyroid Association. So that's what I'm going to be presenting now on this slide. So estimating your risk of recurrence using all of those different variables we talked about. You can have a high risk tumor, and that's where the tumor is growing into other neck structures, or because of that, it couldn't be fully removed. There was big, bulky lymph nodes. It's follicular thyroid cancer, and that's gone into several blood vessels. Or the thyroid cancer is moved outside of the neck. And that is very rare in thyroid cancer, but does happen. And if it does, the most common site would be in the lungs. So intermediate risk patients are those that have an aggressive subtype. So the most common aggressive subtype for papillary thyroid cancer would be something called tall cell variant papillary thyroid cancer. Intermediate risk is also when papillary thyroid cancer has gone into the blood vessels, or if there's small to medium-sized lymph nodes. So in high risk, it was big lymph nodes. In intermediate risk, it's small to medium-sized lymph nodes, and at least 5 of them had cancer inside. So then we can think of low-risk patients as patients where the tumor was entirely inside the thyroid. The surgeon then took the thyroid out, so the tumor was completely removed. There either weren't any lymph nodes involved, or they were tiny. They were only 2 millimeters, which means really that they were microscopic, and the surgeon just took out little lymph nodes that they just looked normal. They were just 2 millimeters in size. And then there's no spread elsewhere. So that's the sort of breakdown. And now there's lots of like nuances and things, but that's kind of the general gist, which is basically, were they able to get the whole thing out and had it spread anywhere? So this is a really famous figure that I think you don't need to know anything about this, okay? The only point I'm trying to make here is this is a famous figure that comes to us from the American Thyroid Association guidelines that physicians use a lot to look up the risk of their patient. And so there's all these different variables. And my only point here was that this is a spectrum of disease. So even though we are clustering patients into low or intermediate, it's really a spectrum of disease. And so someone in the low risk might have a 5% risk, but you can see here that someone in the intermediate risk has 3 to 8%. Well, those overlap, right? So it's a spectrum of disease. The other thing, so prognosis based on initial risk stratification. So if based on all of those variables, we said this is a low risk of recurrence tumor, it's unlikely it will grow back, then what is unlikely? The rate of recurrence in those tumors is usually 3 to 5%. And in intermediate risk patients, it's somewhere between 15 and 40%. You can see that that spread is a lot greater. And that's because there's a lot of different types of patients that can qualify for intermediate risk. So of course, then they won't all have the exact same risk of recurrence. So some practical tips when thinking about our initial risk. So is my tumor a low risk tumor, an intermediate risk tumor, that sort of thing, which is make sure your medical team has access to both your surgery report, also known as an operative report, and your pathology report, which is what the pathologist saw under the microscope. And that's really most important for patients where they're going to be followed at a center that is different from where they had their surgery or their workup. So sometimes I'll see patients that were in the United States or were elsewhere, and then they come to Canada and they've had their surgery elsewhere. And so it's super helpful to me to have copies of the reports to actually go through and see, well, what was the size of your tumor? Were there lymph nodes involved? Did the surgeon get the whole thing out? All of that helps tremendously in understanding how I should be monitoring them. The second is ask your doctor, what is my stage and my ATA risk? If it's not clear and it's not communicated, it is something that's helpful to know, presuming that you want to know it, obviously. Not every patient does want to know it, but if you're looking for information to understand what to expect next, I think those are the two things that you should be asking about right up front. I will say that in some parts of the world, they use different staging systems. So in North America for sure, in many Western countries, and actually in most of the world, we're using the AJCC staging system for thyroid cancer, and we're using the ATA risk of recurrence. However, there's lots of different validated systems, like at least 10 or 15 others. And so that's not wrong. They just use different ones. And just like anything else, one becomes popular and becomes used a lot more. So then that's what we use. So, ask about your stage or ATA risk. And if it's not ATA risk, it's just communicated in a different way, but it's really the same information. So the final thing that is more of a caution is that there is a difference between sort of estimating the risk of a group and then figuring out what your individual risk is. And what I mean by that is, so if it's a low risk patient, then the risk of recurrence is around 5%. And so you can see that in this picture that I've put up. If there's an intermediate risk tumor, then the risk of a recurrence in this whole entire group is about 20%. However, when it's down to an individual, they'll either have a recurrence or they won't have a recurrence, right? And so it just gives you a general guideline, but it doesn't mean that if you're in a high risk group, you absolutely will have a recurrence. And it doesn't mean that if you're in a low risk group that you'll never have a recurrence, because as you can see, even in the low risk group, there's one person who ends up being that 5% that has the recurrence. So it's sort of a guideline, but it's not written in stone that that's exactly how an individual case is going to go. And I think that's important, especially when comparing or if talking to, a support group online or anything like that, is just understanding that these are group risks. So they're at the level of hundreds of patients who are categorized in the same way, and it doesn't dictate your own individual risk. So the next part is dynamic risk stratification. So what does that mean? This is a term that we use a lot now in thyroid cancer, and dynamic risk stratification means we use clues after the surgery, such as your thyroid tumor marker, that's called thyroglobulin, or your imaging, which is usually a neck ultrasound, but sometimes CAT scans, sometimes MRIs are used. And so we put those things together after your thyroid's been removed to assess whether the thyroid cancer is gone and to predict in whom it will grow back. And so it's dynamic because your estimated risk of a recurrence can change over time. And so I'll give you an example of that. So some people will start out as a high risk of recurrence based on those variables that I had showed on an earlier slide, but based on having an excellent response, their risk of recurrence will fall dramatically. So that you start out high risk, but now it looks like your tumor is totally gone and your risk falls really low. Other patients might start out with a low risk of recurrence, but then based on their response So for example, they might have a high tumor marker, or there's something suspicious on their imaging. Their risk of recurrence actually increases, even though they were initially called low risk. So what I'm saying is that you figure out what someone's risk is right after the surgery is done with all those variables we talked about, but then you keep kind of reevaluating that risk, and it can change over time depending on your tumor marker number, depending on what your imaging, your neck ultrasound or your CAT scan, that sort of thing is showing. So that's what makes it dynamic. It changes over time. So I'm going to give a case example where we actually use this. This is a patient of mine who's a 28-year-old woman, and she had her total thyroid removed, and she actually had a right neck dissection. And the surgeon found a 3.5 centimeter classic papillary thyroid cancer. There were 20 lymph nodes removed, and out of those, 8 of them had papillary thyroid cancer in them, and the largest was about 2 centimeters. Post-operatively, she had a pretty low tumor marker number, so 0.3, and under 1 is usually kind of the guideline, although there's lots of nuances there as well that kind of go beyond the scope of this talk. So her initial risk stratification, she has stage 1 papillary thyroid cancer, and her ATA risk is an intermediate risk, and that's because of the lymph nodes that are involved. So her initial treatment, I gave her 30 millicures, which is a low dose of radioactive iodine, and there was no evidence that the thyroid cancer had spread anywhere outside of her neck. And then I kept her TSH between 0.1 and 0.5. We'll talk about that a little bit later. And so there's 3 scenarios for how this patient could respond. In scenario 1, at 6 months and at 12 months, I see her and her tumor marker is negative. And then at 12 months, her tumor marker is again negative. So it's undetectable. And the neck ultrasound is normal. There's nothing found. In scenario 2, her tumor marker is elevated. It's at 1, but I can't find any abnormal lymph nodes in the neck ultrasound. So the imaging is normal. And then at 12 months, it's the same story. Her tumor marker is elevated, but her neck ultrasound is again normal. In scenario 3, the tumor marker is elevated, it's 1.5, and her neck ultrasound shows an abnormal looking lymph node in the neck, and then we biopsy it and it's papillary thyroid cancer. So she's having a recurrence that's now proven. So all these patients started out as the same patient. They were ATA intermediate risk of recurrence, but each one had a different response during monitoring. So how do we think about that? So that's where response to therapy definitions come in. And what that really means is, what's the status of your cancer? Is it gone? Is it going to grow back? What's the chances of that? And so that's these definitions are basically excellent response. And that means that your tumor marker is negative and your imaging, usually a neck ultrasound, is negative. There's a category called biochemical incomplete response, and that means your tumor marker is up, but we can't find anything on the imaging. It's just the blood work that says that there's some TG hanging around. Structural incomplete response really means that thyroid cancer has been found on imaging. It's a structural disease. I can see it, and it could be a lymph node or it could be elsewhere. And then there's this kind of wastebasket category, basically, which is indeterminate response, which really means there's either a slight elevation of thyroglobulin, but we don't know what to make of it, or there's something really non-specific on the imaging, just a little glob of tissue, but again, we don't know if it's cancer or if it's not cancer. So looking back at our 3 scenarios for that patient, the patient that had negative tumor marker and negative imaging, that patient would be called having an excellent response to therapy. The patient where the tumor marker is elevated, but the imaging is negative, has a biochemical incomplete response. And the patient where the tumor marker is up and the imaging has shown a lymph node, we biopsied it, it's papillary thyroid cancer, come back. So this is a structural incomplete response, which means the thyroid cancer has been detected back. So what can you expect in terms of your initial ATA risk, which is that low, intermediate, or high that we talked about, and what your response to therapy will be? And so let's look at these column by column. I think that's the best way to break it down because it is a lot of information. So if someone is stratified or staged as a low risk of recurrence patient, then there's an 80 to 90% chance that they will fall into the excellent responder category, which means their tumor marker is negative, their ultrasound is negative. And then there's only a 2 to 6% or 2 to 5% chance of a recurrence. That's why they're low risk. In an intermediate risk patient, there's about a 60% chance that they'll fall into the excellent responder category and a 20 to 30% chance that there will be a recurrence at some point. So that's why they're in the intermediate risk category. So how do we use this is that we reassess a patient's risk over time. So what I mean by that is if you start out at low risk and you have an excellent response to therapy, your initial risk of thyroid cancer growing back was deemed to be 3 to 5%. But now that you've had an excellent response, your tumor marker and your ultrasound is normal, your rate of recurrence is now 1 to 4%. So that's not a whole lot different, which basically means low risk patients, they do well and they have excellent prognosis regardless. But what is really helpful is that if you started out as an intermediate risk patient and had an excellent response, so I saw you at 6 or 12 months, tumor marker was negative, the ultrasound doesn't show anything abnormal, then your risk started as 15 to 40%, but now it's actually only at 1 to 4%. So it's fallen dramatically over time. And that I think is really important and really meaningful in terms of providing information to patients, reassuring them that actually things are going very well, and also in modifying our approach to how aggressive we need to be with the monitoring. So that's where I come to the risk stratified approach to monitoring. So what is disease monitoring? How do we follow patients? And I've already mentioned this in a number of different ways, but just to go over it. So there's blood work that you can get for papillary and follicular thyroid cancer, and that's the tumor marker thyroglobulin. Importantly, this is only for thyroid cancer. So it won't give you any information about your risk of any other types of cancer. You still need screening tests, things like pap smears and colonoscopies and that sort of thing. This is just specific to thyroid cancer. And if the thyroglobulin level is going up, if there's elevations, that could indicate a tumor recurrence. So the other thing that we always order with the thyroglobulin are thyroglobulin antibodies. And the best way to think about the antibodies is if they go super high, you just can't really rely on the tumor marker anymore. You can't use it as a tumor marker. So that's really why we do this test, is just to make sure that the tumor marker is reliable. And then the final thing in the blood work that we would do is a TSH, and that's because it helps us select the synthroid dose that's best for you, for your body, and also for the suppression of the thyroid cancer. And so we would try to keep your TSH in the target range, and I'll go over the target ranges coming up. So that's the blood work. The other way that we monitor is through imaging. And so the most important is a neck ultrasound. And it's really important to have access to high quality neck ultrasounds, especially post-operatively. If you've had thyroid surgery, ultrasounds are a lot harder to do and to read, and so require quite a bit of expertise. And so I'll explain a little bit more about that on the next slide. Other imaging is done as needed, but is much less common, especially in patients who have low or intermediate risk disease. And so that's CAT scans, PET scans, bone scans, MRIs, radioactive iodine scans. There's all sorts of scans that you can do, and you do different ones for different reasons. And that's just a good thing to ask your doctor is, do I need any of those? And if not, why? And then clinical visits, the most important thing is just feeling your neck, of course, and seeing how you're doing overall and feeling on your synthroid. So that is disease monitoring in a nutshell, which is blood work, imaging, and clinical visits. And so why do we call it a risk stratified approach to monitoring is going to be coming up next. So the importance of, this is just a little aside, okay, a caveat is, what's the importance of high quality neck ultrasound? So ultrasounds are what's called operator dependent. Operator dependent really means it matters who's doing it. And so I finally came up with an analogy I think I like, although I'm always kind of reworking these just to figure out how I want to explain this. And so the analogy I came up with is, this is a bobcat or an excavator, and this is operator dependent. So if, it depends the skill level. So if I get in this versus a highly skilled person, the way that the bobcat moves up and down, whether it's going to hit things, matters depending on who's driving the bobcat. So I'm obviously not going to do a good job, and I wouldn't trust myself swinging it around in front of a building or in front of anyone else. So that is operator dependent versus an elevator where whether I get in or a highly skilled person gets in and we just press a button, that elevator goes up to floor 10 no matter what, in the same way. It doesn't really matter who's pressed the button, it will move in the exact same way. So this is more like a CAT scan where the modality is really what's important, whereas an ultrasound really depends on who's doing the ultrasound, okay? So a risk stratified approach to monitoring basically means that we figure out what your risk of recurrence is initially, so low, intermediate, or high, based on the variables before surgery, during surgery, after surgery. And then that's what actually dictates our initial management. So does the surgeon think you need your whole thyroid removed or only half? Do you need radioactive iodine afterwards? And if so, what dose? What type of TSH target should you be striving for? Is this someone who we need to get the TSH fully down by giving a really high dose of Synthroid? So all of that initial management is actually dictated by what the risk is initially. But then also the monitoring strategy. So what types of tests do you need, such as CAT scans versus ultrasounds versus PET scans, et cetera? And how frequently do you need to be seen? Is it every 3 months or 12 months, every 2 years? And the clinical visits. So all of that is modified based first on the low, intermediate, and high, and then second on the response to therapy. The response to therapy was what we talked about with the tumor marker and the ultrasound. So I'll show what that means in this table. So again, let's go down the columns because I know these tables have a lot of information. So what is a risk stratified approach to the initial 12 months post-operatively? So you've had your surgery in the first year after that. And this is the time that we establish your response to therapy. So if it's a patient who started with low risk disease, then we would do your baseline tumor marker, which is at 6 weeks after the surgery. Or a minimum of 6 weeks after. We don't want it too soon because the tumor marker takes time to come down after surgery. And then usually at around 12 months, we will repeat the tumor marker and the ultrasound. And so that's the first 1 year. If the patient started with intermediate risk disease, then of course we still need that 6-week post-op tumor marker. And then we would see them every 6 to 12 months, usually with the tumor marker and a neck ultrasound. And I've written that all these other tests like CAT scans, MRIs, et cetera, are discretionary, which really means it depends on the case and the center. And then for high risk patients, which isn't the focus of our talk, but just for completeness sake, we're still going to do the baseline testing. And then we might be seeing them at 3 to 6 month intervals, and they'll have a neck ultrasound. And usually high risk patients will get a CT scan at some point. It's unlikely that it'll just be an ultrasound. So that is basically the first 12 months, and that's where you establish your response to therapy. So then what's different in this slide is the previous slide, we were talking about your initial risk, low, intermediate, or high. And in this slide, I'm saying, well, now that we have a response to therapy, how are things going? What is the status of your thyroid cancer? Now we can define patients as having an excellent response to therapy, an indeterminate or biochemical incomplete, which means that the thyroglobulin is up, but your imaging looks normal, or a structural incomplete, which means the imaging has found something. And so now we're using these response categories to figure out how we should follow you for the remaining 4 years. And so that's for excellent response, things are going well. There's no evidence of thyroid cancer. And so we're doing usually the tumor marker every year and the neck ultrasound every 1 to 3 years. And this is highly variable. There's not a lot of high quality evidence to say how frequently should you do the ultrasounds, and it really depends on where you live, who your doctor and your team are. And so some people will do them every year and some people will do them less frequently than that, and they just depend on the thyroglobulin. If this goes up, then they'll do the ultrasound.
It's 13 hours.
Sorry guys, that's my laptop warning me what time it is. Okay, and then if the tumor marker is already up, likely you need to be seen more frequently. So that's every 6 to 12 months or somewhere in there. We can do 7, 8, 9, it depends. And then an ultrasound is usually done at each interval, and we might be doing some of the other testing as well. And then if we have something on imaging that we're pretty sure that's thyroid cancer recurrence, like a small lymph node or something like that, then we're really seeing patients every 3 to 6 months, and we're doing the tumor marker, ultrasounds and sometimes CAT scans and other scans. It really depends case by case. So that is essentially the approach, or risk stratified approach to monitoring. So my practical tips from this section is, at each visit, you should ask your doctor to go over your tumor marker, the thyroglobulin, and if done, your imaging results. And a lot of my patients will bring, their a binder or whatnot to write in, and they'll keep their tumor marker numbers, or I'll print them off the flow sheet that shows how it's changed over time. And so those are the two main things to ask about. Well, what is my tumor marker doing this time? And if it's going up, what does that mean? And then what does my imaging look like, your ultrasound or your blood test? If your thyroglobulin is rising, this could mean that the cancer is growing back. But my warning is, there are many reasons why your thyroglobulin can be rising. So make sure not to rely too much on Dr. Google, and instead speak to your treatment team to figure out what that thyroglobulin rise can be. I know that in Alberta, where I practice, we have a patient portal, which means you can log in, you can look at your lab results even before you come and see me. And there's been times where patients are really worried, and understandably so, and their tumor marker is elevated, but there's a very good reason for that. That's not cancer growing back. And so it just sort of reminds me to say, build that caveat in, which is there are many other reasons why your tumor marker can rise. Only one of them is that the cancer is growing back. Similarly, neck ultrasounds are done to look for thyroid cancer in the lymph nodes in the neck, obviously, because it's a neck ultrasound. And so that's the reason we focus on this area, is because that's the most common place by far that papillary cancer grows back. Follicular has less lymph node metastases. So again, this is where it comes up to the specific case and the details of the case to figure out what's the best way to monitor. And then I said it is very common to see scar tissue or normal lymph nodes on a neck ultrasound. So finding something on a neck ultrasound does not mean you're having a cancer recurrence. It's really quite common after a thyroid comes out to have scar tissue left behind, and that's visible on a neck ultrasound, and it will pretty much be there every time. So I always pay attention to it. I compare it to the last time. I make sure it doesn't look any different, but otherwise I just, realize it's scar tissue and it's going to be there. And it's very, very common. I see that in most patients. And then the most important way to understand the status of your cancer is to communicate with your treatment team and stay informed about your test results. So I think, communication is by far the most important thing. And it's part that I love about my job, and just trying to, patients can understand why you're recommending this or that or the other thing if they understand the rationale behind it and are really informed about their treatment results. So okay, so the last part is about TSH suppression. And so based on your initial risk, so that low, intermediate, or high category, your TSH target will be different. And that means that the amount of synthroid we think is right for you will be different. And so for low risk patients, and again, this will slightly depend on what assay, what country you live in, because these numbers could be slightly different. The assays are different. So you've got to sort of, this is a general thing based on the most common units and platform, but just use it as a guideline, because the point is not the exact numbers. The point is just that the higher the risk goes, the lower we want the TSH. And we achieve that, we get that by putting the patient on a higher synthroid dose. Okay, so it just matters what your initial risk is, and that dictates where do I want your TSH sitting in that normal range. And then that is modified over time. So long-term TSH targets depend on your response to therapy, that part that I talked about with excellent responders versus structural incomplete, et cetera. But also, what is the risk of TSH suppression? And so you can see that putting someone on too much synthroid, meaning you've made them hyperthyroid, is more of a risk in patients who are post-menopause, patients who have really high, really fast heartbeats, patients who have thinning of their bones, osteopenia or osteoporosis, which is when your bones are thin that they're at risk of breaking, in older patients, and in patients who have an arrhythmia of their heart called atrial fibrillation. So essentially, you have to balance these risks with, getting to your TSH target that we want based on your initial risk of recurrence, low, intermediate, or high. So The practical tips from this part is when your TSH is suppressed, meaning you're hyperthyroid, you are at risk of bone loss, which is called osteoporosis, and that can make your bones more fragile and more likely to break. You need to reassess your TSH target with your treatment team over time. It's not going to necessarily stay the same over the first 5 years and beyond. And then your synthroid dose may need to change during the first 5 years of follow-up, depending on what your response to therapy is. So I do sometimes see patients who have had thyroid cancer 20, 25, 30 years ago, and they have no evidence of thyroid cancer in their body. Their tumor markers totally negative. All of their imaging studies have been negative, and yet they're still on a really high dose of synthroid and their TSH suppressed. And that does concern me. And I usually reduce their synthroid dose slowly because I'm worried that in that patient, there's no real added benefit at this point of a high dose from a cancer perspective because their cancer's gone. But there is a risk of that treatment because of osteoporosis primarily, is the thinning of the bones and breaking of the bones. So that, is a not uncommon scenario where you kind of were started on a dose, no one really looked at it, and then I'll see someone, a decade out or more, and then reassess their synthroid dose. So final piece is duration of long-term monitoring. So we use this ongoing risk stratification to guide our long-term monitoring strategy. There is no one size fits all. So patients are, it's hard to compare directly. It really depends on your particular case and all of the details that we talked about today. But in general, patients who are having an excellent response to therapy, there's no evidence of thyroid cancer, should have lower intensity and frequency of monitoring over time. So you may not need ultrasounds every year. You may not need blood testing every year. You can start to sort of space out those intervals. Conversely, patients who have a high or a rising thyroglobulin or suspicious imaging should have higher intensity and frequency of monitoring. So maybe you used to be seen once a year, but that may not be appropriate anymore, and you need to shorten that interval and actually be reassessed every 3 months, 6 months, or 9 months, something like that. So these things change over time, essentially. The final thing is there's not a lot of literature to guide us in terms of how long should you be monitored beyond the first 5 years. So the duration of follow-up is highly variable depending on where you live and who your treatment team is. In some centers, patients are monitored for up to 5 years and then discharged back to usually their primary care doctor or their family doc, or different words for the primary care physician, if they don't have any evidence of disease. And that's because the majority of recurrences, around 75% recurrences, they happen in those first 5 years after your surgery. So it's much less likely that you'll have a recurrence later on. Since late recurrences do occur though, because around 25% of them will happen after the first 5 years, a lot of experts advocate to monitor patients with thyroglobulin long-term. So not necessarily imaging, but to use the tumor marker. And if it's negative, and then all of a sudden it starts to go up, that's a good reason to do the imaging and reevaluate the patient. So a lot of, although we don't have good high quality research to tell us what to do, most centers will discharge patients around 5 years, but then they will continue with their primary care doctor to have their tumor marker done pretty much on a yearly basis forever. So that's the most common, but of course, highly variable depending on where you live. So that's everything. And there is a session coming up by Dr. Amanda LaGreca on the importance of long-term follow-up for papillary and follicular. So she's going to be talking, I believe, tomorrow. I might want to check that out because she's going to talk about beyond the 5 years, and we'll go into more detail about that. So that is everything from my end. That's just, it's time for discussion and questions. I'm just going to stop sharing my screen so that I can see you guys.
There you go. Do you have, can you see the Q&A section?
I can now. I couldn't while my screen was.
Well, yeah. Okay, so you can just go through, and yeah, it's 3:10. You have until 3:30. So go ahead.
Okay, perfect. Okay, so the first question is, does low-risk papillary microcarcinoma after a total thyroidectomy also require 5 years for you to be declared cancer-free? So this is a really tough question, and I would say generally no. Incidental papillary microcarcinomas, meaning you had your thyroid removed, maybe it was for another reason, a nodule or something, and now a small papillary thyroid cancer, usually less than a centimeter, is found. In that case, it is again center to center dependent, but the vast majority of places will follow patients for at least the 1 year. And once you've had a response to therapy that's excellent, at that point you're discharged and essentially declared cancer-free. So that's the most common thing by far for papillary microcarcinoma. In my practice, that's sort of how we do things. There are patients who honestly just it is partly patient preference, because if a patient is really, really concerned about this, it was a totally unexpected finding, I might hold on to them for a couple of years. And that's because I want them to feel really comfortable that things are gone, and then discharge them at that point. So usually less than 5 years required to declare them cancer-free. How many items from each, so Stephanie's asking, how many items from each risk column do I need to be considered that specific risk? Yeah, so only one. So you don't need to meet a number of different criteria. It's if you have anything within that risk column, then you qualify for that risk. And it's obviously the highest risk column that you qualify for. So for example, if you have a few features that are of intermediate risk, but then a few features that are of high risk, your risk is high risk. So it's always the higher of the risk that gets the trumps the other one. Okay, Nadine says, good afternoon, and thank you for sharing your time. Thank you, appreciate that. After lobectomy and total thyroidectomy in July, I'm trying to choose whether to undergo RAI or not. So far, it appears I'm categorized low. Tumor was 1.3 centimeters, no lymph nodes, no vascular invasion. Endocrinologist did an ultrasound blood work and said RAI is a choice in this case, not a must. At 60 years old, is it okay to opt out? Yeah, so this is a really good question. And so the TSH, the tumor marker, everything's looking pretty good. And what I would say is, in the low risk category, in terms of the evidence for radioactive iodine, there's actually no evidence. So I should rephrase, there's lots of studies, and what those studies show is that radioactive iodine in low risk patients doesn't actually reduce your risk of recurrence. And I think part of that is because your risk of recurrence is already excellent. It's in the 1 to 5% range. And then if you treat that group of patients with radioactive iodine, they still have a 1 to 5% chance of recurring. And so there's not really an added benefit. Long-term survival for low-risk patients is typically 98, 99%. And so we also can't improve that. And so the majority of centers will really say, yeah, it's selective use, you can use it, but the risk benefit ratio is skewed towards, there's a risk because you're taking on radiation, but there's not really an added benefit that we've measured in any of the studies. So that is a change. It's a paradigm shift. It's different than what we did 20 or 30 years ago, because at that time, basically everyone got radioactive iodine. In terms of prognosis, it doesn't improve things. What it does do is it helps the endocrinologist actually monitor the patient going forward, because it makes your tumor marker go to 0. And so now any rise in the tumor marker tells me, okay, the thyroid cancer could be growing back. So it actually helps us with monitoring, but it's not necessary for monitoring. It's just something that's helpful in certain cases. So yeah, hopefully that helps and gives you something to talk about with your treatment team. Next patient, hello, does the number of tumors factor into risk of recurrence? For instance, is the assessment different if a patient has 2 centimeters? So what you're asking about is multifocal disease. Papillary thyroid cancer specifically loves to be multifocal. It's very, very common to have 2 or 3 or 5 or whatever amount of small tumors. And it does not factor directly into risk of recurrence. Multifocal disease sometimes raises your risk of having lymph node spread, and that will increase your risk of recurrence. Okay, so unless there's lymph nodes involved, it doesn't in and of itself raise your risk. Tony Dunn, in scenario 3, so that was the patient who had a tumor marker elevated and their ultrasound showed a funny looking lymph node. So in scenario 3, you did FNA, but what size of lymph node can or should be biopsied? Okay, one is the way that the American Thyroid Association guidelines would answer this question is that they would say in the central neck, you should wait until a lymph node is at least 1 centimeter in size. And in the lateral neck out here, you should wait until it's about 1.5 centimeters, 1.5 centimeters. I would say that that's generally a good rule to follow, but also depends on specific factors in the case. And that's really where your endocrinologist should be talking to your surgeon, looking at CAT scans to see where the lymph node is sitting in relation to your food pipe and your windpipe and things like that. So it really depends on the location. It depends on the overall size, which I just stated, but also how quickly is it growing over time. So there's a number of different things you need to use, but in general, just in terms of size cutoff, 1 centimeter here, 1.5 centimeters here, and then you would stick a needle into it to figure out what it is. I did want to ask, what number should your thyroglobulin test be at after 2 years since surgery and stage 1 at the time of the thyroid removal? So in general, it should be, if it's been total thyroidectomy, the whole thyroid has come out, on most assays, which again, they're different in different countries and different places. In most assays, it should be under 1. However, it really depends on a number of different things, including what your TSH is, how much normal thyroid tissue was left behind. Sometimes surgeons take out the thyroid, but to protect your nerve, they'll actually leave a little glob of normal thyroid tissue around. So that influences your TG number. Whether you make antibodies influences your TG number. So there are a lot of different things that you have to look at. So in general, it should be kind of under 1, but it's not always under 1. And sometimes that's okay. And that's not because there's tumor still there. Okay. Since papillary thyroid cancer tends to be slow growing, is the 5-year mark post-treatment still a useful milestone? Is there a typical time frame in which PTC occurs? Yeah, so I did answer that question in the very end. And so still, even in the recent studies that look at this, around 75% of recurrences happen in the first 5 years. I would say a lot of the meaningful recurrences, so not just a tiny lymph node that you might have for another 20 years and monitor, but the recurrences where you really have to act. You have to do more surgery, more radioactive iodine, some other type of treatment like radiation treatment. The vast majority of those clinically relevant recurrences, they happen in the first 5 years. So it's still a useful milestone, but because some patients will recur later, usually in lymph nodes, and it's slow growing, right? If it took 20 years for that lymph node to be detected on a neck ultrasound, it's usually not a fast growing thing. So because though that can happen sometimes, that's why we still do the thyroglobulin. And some people will even do neck ultrasounds over 3 or 5 years, something like that, for those late recurrences. Okay, does risk recurrence refer to recurrence within 5 years? Risk of recurrence does refer to the recurrence usually in the first 5 years, just because that's where the majority of the studies that were done, that's as far as they measured out. Okay, so yeah, it is for the first 5 years. And how do I define a very high thyroglobulin antibody? Very challenging. It really depends on what was your antibody to begin with. And so really it's more about the trend over time than the absolute number. And it also depends on the assay and that sort of thing. So, but very high, it means different things in different people. It could be 50, 60, 100, or it could be like 2000. I've seen everything in between. So it really depends on what your trajectory has been. Some people, when the thyroid comes out, their baseline antibody level is just really high. That's just what their immune system does. It's not because of their cancer or anything like that. It's just their immune system makes a lot of this antibody. And so it takes a very long time, years, for it to kind of trend downwards. As long as it's trending downwards, even if it's 2000, I'm saying the trend is in the right direction and I'm happy with that. Jim asks, what if your TG antibody is present? Are there any other blood markers? Also, I heard that there are a couple of labs in the US that can prepare the TG and TG antibody values that can separate them. Okay, so Jim, what you're talking about is mass spectrometry. So the majority of our assays the majority of hospitals will use a particular way of testing for thyroglobulins, where if you have high antibody levels, then the thyroglobulin can't be used. And There are no other direct tumor markers. In most cases, then what the doctor is doing is really relying on the imaging and the overall risk stratification, right? However, some hospitals have access to what's called mass spectrometry, MS. And so the LCMS platform, the way that it's tested, it can actually kind of get rid of the interference that happens from the antibodies. In Canada, we have access to it in Vancouver. So very occasionally, I will send my patients there if I think that this is going to change the way that I'm monitoring them, or there's something that's not making sense. However, most of the time, I actually don't need it because I'll have a different way of sort of, reassuring us that there isn't disease, or if I know there is already, it wouldn't really change anything for me, whether the tumor marker is this, that, or the other thing, because really I'm already watching them with the CAT scans or the PET scans or whatever. So hopefully that helps.
Oh, you have 10 minutes, just to let you know. Carry on, you're doing very well.
Okay, I'm knocking these out because I don't know how many are left. Okay. Okay, so hopefully we'll get through, I don't know, 5 or 10 more or something. So Ingrid, hopefully that answers your question about the thyroglobulin antibodies, just because we've talked about that a little bit. So Susan, I had a total thyroidectomy in 2014, stage 1 papillary. I do blood work every 6 months and yearly ultrasounds. My endocrinologist stopped doing physical exams during the pandemic. He has not resumed them. Yeah, so you should not be concerned. I would say, realistically, if your neck ultrasounds are normal, it's very unlikely for us with our fingers to feel stuff because, and the reason why is I'll tell you, as someone who sees hundreds of thyroid cancer patients, this is what I do for a living and I'm feeling people's necks all the time. Still, my fingers can only detect lymph nodes that are around 1 centimeter or more, and your ultrasound can detect lymph nodes that are 2 or 3 millimeters. So usually the ultrasounds actually find them first, and then I find them later. I think neck ultrasounds become a lot more important after the first 5 years, where you're out, you're not seeing an endocrinologist necessarily, you're doing your thyroglobulin every year, but now you're not getting ultrasounds every year. And so I think at that point, it's really important that your doctor lay a hand on your neck, make sure there's nothing sort of, overtly abnormal, like a lymph node or something like that, or tissue growing. And then that would trigger them to do an ultrasound or a CAT scan. So that's when it's more important. I will echo just some compassion for the whole situation due to COVID-19. I've seen a lot of my patients less frequently in person and have relied more on neck ultrasounds. We're trying to transition back. I think there's a lot of value personally for me. I find it much easier to follow patients in person, to feel their neck, to make sure that what I'm saying is getting through. It's really hard to actually understand how much of what you're saying is making sense to someone when you're on the phone. So there's a number of reasons for me that virtual care is challenging, but that scenario that you've described isn't really concerning. Okay, next is if it's close to the laryngeal nerve and the genetic testing is benign, but the thyroid ultrasound biopsy indicates cancer such as Bethesda, so Bethesda 6 carcinoma, hypoechoic microcalcification, is monitoring an okay strategy in this case. Okay, so this patient is, this person who's asking the question is asking about whether active surveillance is okay. So basically, someone who's had an ultrasound, has a suspicious looking nodule, and it's been biopsied and proven to be papillary thyroid cancer. And what they're asking about is it okay to monitor it as opposed to going to surgery? This is a strategy that's become much, much more popular over the last 5-10 years, especially in North America and in parts of Europe, where it was already somewhat popular in other countries like Japan for the last 20 years or so. And there, the most important thing that I would say to that is it really, I think you should, if you pick monitoring, there's 2 things that you really need. You need a doctor who knows what they're doing because they've got experience with active surveillance, and you need access to high quality ultrasounds, because really it's going to be the ultrasound that tries to pick up whether the tumor is starting to grow or spread, or is it too close to the nerve that it's a bit risky to watch. But there's many patients that are appropriate to watch and not do surgery. And the obvious advantage of that is that you get to keep your thyroid. As someone who follows so many patients that don't have a thyroid, that cohort of patients has a lot of problems with quality of life issues because of fatigue, weight gain, mental fog, things like that, where their Synthroid, no matter what I do the dose, it doesn't really alleviate those symptoms completely. So if you can keep your thyroid, I personally see the benefit of doing that, because I'm thinking, okay, well, you can avoid those quality of life issues, but it's not safe in everyone. And the way to understand whether you're eligible or not is to have a doctor who's comfortable doing that, active surveillance, and have really good ultrasounds. So in those two settings, and if the doctor thinks it's safe to watch, it's not so close to the nerve that it's dangerous, then yeah, that's definitely a viable strategy. What are some examples of those non-cancer reasons for elevated thyroglobulins? So the most common by far would be that there is a little nubbin of thyroid tissue left behind, a thyroid remnant. And then under some TSH stimulation, so the TSH is a hormone that your pituitary makes. It stands for thyroid stimulating hormone. So when it's around, it will go and stimulate whatever thyroid gland, whatever thyroid tissue there is, and that can grow over time. And so that can raise your thyroglobulin. In lobectomy patients, there's like a bajillion reasons, because you've still got half the thyroid in place. And so you can have something called nodular hyperplasia. You can have an actual nodule that's just benign growing in there. So there's lots of different reasons. And the other thing I'll mention is that TG is not static. It kind of goes up and down. And even if I were to measure your thyroglobulin today and then a week from now, I wouldn't get the exact same number. There's always some kind of up and down that happens, which is why we look at trends. Does it keep rising, or is it just that sometimes it's 0.3 and sometimes it's 0.5 and sometimes it's 0.4? It just kind of keeps going up and down.
We have 4 minutes left. So
okay,
one or two, and then.
Okay, so let me look at ones that maybe we haven't talked about. Where's them? Okay. Are neck ultrasounds done in a standard way? My last ultrasound after initial left lobectomy, it seemed like the appointment went very quickly. It seemed like they only checked my thyroid and not the nearby lymph nodes. So they should be done in a standard way. And it's a Society of Radiology, whose name is escaping me because that's really long, okay? But they have published guidelines on exactly how a neck ultrasound should be performed. And there's like sort of a sequence of pictures that should be taken in the same order every time. And so, yeah, it definitely is something where you're not just looking at the thyroid bed, but you're looking at the lobe that's in place. You're looking at the lymph nodes and that sort of thing. That is a complete exam. So I think it might go quicker because there's less thyroid tissue. They've seen the neck already, multiple times. So yeah, it definitely might go quicker, but they definitely should still be checking all of those areas. I think that would be a complete exam. Okay, and then I think we'll do one more.
Yeah, one more sounds good.
Okay, so Michael says, do you find it difficult to reduce Synthroid dose in patients who have been on a high dose for 40, 50 years? Absolutely. So one is, if you have been hyperthyroid for years, your body is used to hyperthyroid. And so if I were to just drop that person down to normal thyroid, TSH of 2, they're going to feel hypothyroid because you're used to being hyper. That's normal for you. And so, yes, one is I look at their overall risk. Is this someone how hard do I need to try to move your level down? If it's someone who's got atrial fibrillation or they're clearly breaking bones, then I'm pretty motivated to reduce their TSH, reduce their Synthroid. And so we will do that. But typically I do it much more gradually because you just need to give patients' bodies time to accommodate to that. Okay, we're done.
Yeah, I think so. So, I wanted to thank you for joining us today, Dr. Ghaznavi. I think I'll just say on behalf of ThyCa, thank you so much, Dr. Ghaznavi, and look forward to seeing you at future conferences, maybe one day in person.
That would be great. Thank you guys so much for inviting me, and thanks for your time and attention.